everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Hello, everyone, and welcome to another episode of the Surgical Ergonomics podcast. Today, I have as our guest Dr. Marc Rubin, who is a colon and rectal surgeon and has been practicing in Boston's North Shore for 30 years. He is chair of the Department of Surgery at Mass General Brigham Salem Hospital, previously served as the chief of the Division of Community Surgery at Massachusetts General Hospital, and is an assistant professor of surgery at the Harvard Medical School. Regionally, Dr. Rubin has been past president of the Massachusetts chapter of the American College of Surgeons and the Boston Surgical Society. He's also a member of the Quality and Safety Division of the Massachusetts Board of Registration in Medicine. He chairs the Massachusetts Surgical Quality Improvement Collaborative and co-chairs the Mass General Brigham Colorectal Surgery Collaborative. On a national level, Dr. Rubin is past governor of the American College of Surgeons and has served as an associate editor of the journal Diseases of the Colon and Rectum. He has led or been a member of many committees of the American Society of Colon and Rectal Surgeons and the American College of Surgeons. Hello, Marc, and thank you for joining us today on the podcast.
Well, it's my pleasure to be here. Thank you for inviting me.
Of course. Well, let's get started. So, Marc, first off, I'd like you to tell our listeners a little bit about yourself, including your training background and how you arrived at your current role.
Well, I'll quickly run through it. I went to medical school at Columbia and then did my residency at the Beth Israel in Boston and my colorectal fellowship at Leahy Clinic, also in the metropolitan Boston area. And from there, I joined the staff at North Shore Medical Center, which is part of the Partners and now Mass General Brigham network of hospitals. After maybe 10 years in practice, I was the first fellowship-trained colorectal surgeon on the North Shore of Boston, and I rapidly built a very busy practice and eventually came to a point where I wanted to do some other things, have a greater impact, and in 2005 became the chair of the Department of Surgery here. I was initially in private practice, and then in 2014, my multi-specialty group, which I was the managing partner of, we joined the Mass General, and we've been employed as part of the Mass General Department of Surgery for the last 11 years. That's sort of my background.
Great. Thank you for sharing that with us, and happy 20th anniversary. Okay, well, for our listeners, I first met you when you asked me to be a speaker as part of the Boston Surgical Society's annual meeting. And since then, we've been kind of working together as my business partner and I have been providing ergonomics coaching to the surgical staff and proceduralists at your institution. Because of this, I was hoping you could share with our listeners a little bit about your own story as it relates to ergonomics and how that contributed or led up to you setting up this program for the staff at your hospital.
Well, sure. I'll start by talking a little bit about, how I reached out to you or why I reached out to you
Absolutely.
to speak at the Boston Surgical during the year that I was president there. The Boston Surgical, the similar organizations in Chicago, Philadelphia, and New York have been around a long time, over 100 years. Initially, it was mostly general surgeons, but as surgery has subspecialized, the task of leadership in these organizations has moved from sort of general surgery topics to topics that cross all specialties in surgery. And to me, ergonomics was a natural. It was something that everyone needs to hear about and understand, and that can benefit everyone. And your talk was very well attended and had very positive feedback. And as you recall, we combined that talk with a speaker who talked a little bit
Hmm.
about navigating the disability world,
Hmm.
insurance policies and whatnot, and providing some guidance. And I thought that was a great topic for all surgeons. I'll talk a little bit about my personal experience and why it dawned on me that this was such an important topic. And I'll just say that I'll call it ergonomic issue has always been my neck. And I would say as far back as in my early 40s, I had a lot of neck pain operating and after, and kind of powered through it, ignored it like most surgeons do, had some trouble sleeping, kind of figured out how to manage. And then in 2009, I actually had a herniated disc in my neck, and it was very painful. I lost a little bit of the sensation in my left hand, the tips of a couple of my fingers. But, there was no real significant deficit, and I kind of powered through it. And I remember it was really difficult, and it took a couple of years before I was sort of back to normal. But I don't think I canceled a single case, and it was really rough. But I got through it, and that kind of self-reinforced the bad behavior of just ignoring the problem. Well, fast forward to 2022, and I had another event one morning. I woke up and I actually couldn't lift my right arm, my dominant arm. And I kind of had a feeling about what might be going on, but didn't really know. In fact, I had 4 cases booked that day, thankfully with a resident and a senior resident. And I did those 4 cases. The resident really did the cases. I guided her through it. And I called a friend of mine who is a neurosurgeon, one of my division chiefs. And, he was like, I'm setting up an MRI for you, and then you're coming to see me when you're done. And I did. And the MRI showed a very significant disc herniation with impingement, significant impingement of the nerve root. He gave me some steroids. He said, like, if you're not better in 2 days, we're operating. And that's exactly what happened. And I lost a fair amount of motor function and muscle mass in that right arm and specifically my shoulder. It made it difficult, even after months of physical therapy and rehab, to really do cases, large cases that required holding your arm up like laparoscopy and retracting, like using my right arm to retract. It was a serious event, and it occurred to me that I can't be the only guy with this experience. And the thing about these types of injuries, it's a little like smoking or drinking when you're young, and it's a chronic behavior. When you're young, you're doing fine. It's not really bothering you too much. You don't really think you need to do anything. It won't happen to you. But the accumulation of years of the habit result in a chronic injury and compromise to your function. And as I sort of talked to a bunch of people
Hmm.
around my staff, surgeons on my staff, I found many of them were experiencing neck or shoulder or back, or hip problems, knee problems that seem to me to be related to chronic injury. So that's kind of how it came to the fore of my mind that this was an important area. And I was never trained or told anything in my training about ergonomics. I really didn't, it was a complete blind spot.
Well, first off, I want to make sure that I extend my deep thanks and gratitude to you for sharing your story. I think if you look at any of the episodes so far on the podcast, you'll notice that I've, kind of asked people to share as much as what they're comfortable with, or how they kind of became interested in this. And it really goes a long way if people in leadership help shine a light on their problem. Unfortunately, it's from your own journey, right? And similarly from mine, but can't tell you how much that means to, I think, people who might be suffering. Like you mentioned, the rest of your staff, like others, like residents who listen to this or other attendings. And it takes a little bit of that fear and stigma away that, this is not something's wrong with them. This is probably a huge part of our careers as surgeons. There's a lot of repetitive injury, as you pointed out. It's years of cumulative repetitive injury. And there's always an interaction of nature and nurture. And so, some of us are going to get injured, and some of us are, as a consequence of these injuries, will have the kinds of things that you described, need surgery, need additional treatment, need time away from work, and all of these things. So, as you very rightly said, it's really important to shine a light on this and see what we can do. So, thank you. Now, this then leads, I think, naturally into the next question, which is, you saw what was happening around you and you decided that perhaps we needed to do something more. Why is it important for leaders such as yourself and others, not just chairs of surgery, but maybe program directors, wellness officers, etc.? Why is it important for them to pay attention to this issue, especially in the current environment that we're in?
Well, I would say, the first thing is the only way we're going to change this is by leaders taking the initiative, recognizing the importance, and doing something about it. I think that the most important thing, personally, I think from my perspective, has been sharing my story and modeling the behavior of trying to do something about this sort of blind spot. And I think that's led a number of people to feel more comfortable speaking up
Mhm.
when they're experiencing something
Yeah.
and not waiting until they have like a serious problem. I still find that some of the younger surgeons who haven't experienced the problem don't completely get it. The people that get it are the people who have been doing surgery for a while and are starting to feel some
Hmm.
of the consequences of poor ergonomics. And but you gotta keep sending the message out there, and one day this will be part of residency training. In fact, it'll be part of OR design and workstation design. Uh, Surgery, medicine, healthcare is behind in ergonomics. Many industries who recognize, geez, if we don't do this, our people are going to go out. It's going to hurt our bottom
Bottom
line one
line.
day.
Mhm.
They've figured this out long ago that it's
Yeah.
important to take care of your working staff, your workers, and make a small investment now to save a large amount later. So I think
Yeah.
it's important to make sure as a leader that I explain why I think it's important. Try to convince people who aren't yet in the throes of something that they should be paying attention to this, and then go to my administration and and make the case,
Hmm.
and I can make a case with an ROI, a return on investment for the administration if they're, if the wellness case doesn't make it for them, at least the financial case will make it for them. And that's like my job, I think.
Yeah, yeah, no, well said. And you addressed, in these last few sentences, you've addressed a couple of the sort of contributing factors to the high rate of injuries that we see in surgeons. For our listeners, we've talked about this before, but almost 70% of surgeons, doesn't matter what specialty you're in, report some amount of pain from operating. And then if you combine kind of the other features that come under the umbrella of work-related injury, you're looking at almost 90%, describing numbness, weakness, fatigue, etc. But the culture piece is a huge one. And, you and every other guest on the podcast tells us how well and alive this and kicking the surgical culture is, because these words and phrases are very common. I felt something, but I powered through. And I kept going and I kept going until like a 10 by 10 plank was hit. And then I was just, I was not able to function. But, I was just listening to that part where you said, well, I had this feeling that now something big had happened and I kind of knew what, but I had 4 cases and I went and did them with the resident, right? And what I've seen is whether it's at the resident level, a couple of episodes ago, we interviewed a chief resident in urology, and it was the same thing, powering through. So your initiative as a leader to share your story helps people understand that, this is if we intervene early, maybe it doesn't have to get there. We don't have to power through, but also changing a different level of the culture, which is our administration, right? So you can change the culture or help change the culture of the physicians and surgeons around us and the other operative staff around us. But then there's changing where the financial impact occurs. Kind of continuing with that theme, other leaders who might be listening to this podcast, maybe they want to know, well, Dr. Rubin, you just said you can make a financial case for it because that's often what we need to do. So if they're interested in improving the physical wellness of their teams and improving ergonomics, both awareness among their staff as well as working in OR design, etc., how do they go about making the business case? And would you be open to them reaching out to you?
Well, I'm 100% open to anyone reaching out to me, and I can share the things I tried that failed and the things I tried that were successful. The first thing to say is we're in a pretty good time right now for this because there is a big wellness thing going on. And this, to me, is the essence of wellness. Wellness really has focused pretty heavily on mental health in our profession, but physical health is certainly as important, I would say.
Yeah.
And ultimately, I was able to tap into resources,
Mhm.
grants for wellness that maybe 5 years ago wouldn't have been available. And I would say that the people that were in charge of these funds were refreshed to see something like this rather than some of the things that were most of their requests were for things that helped people's mental health, be it yoga or massage or like all these things that we were trying to do to correct for the underlying problems
Problem.
that
The
exist in
system
healthcare today.
problem.
But
Right.
this was something that they hadn't sort of really heard of before.
I
You know,
see.
and when I went to my administration, so that was part of the funding came
Okay.
from that. When I went to my administration, I had a whole presentation. In fact, I showed a presentation that showed not just for physicians, but for nurses and techs,
Hmm.
how many were affected and how much time was lost and what
Hmm.
the financial impact of that might be for an organization as large as ours. And then that kind of thing sort of was I'll call it sometimes my hospital president calls that soft money like that's like yeah that might happen in the future. So I said, you know, I've been out for 6 months. You lost 200 cases because I
Right.
couldn't operate. Okay, let's do the math just on that. That
So,
2% of us,
mhm.
right? You know, you're looking at a lot of lost revenue and that kind of computed a little bit better, I think. When you talk about what it costs to have a traveler nurse replace an employed nurse or a traveler tech replace an employed tech or a surgeon go out, or it's not just surgeons, it's gastroenterologists, it's
Interventional
interventional
radiologists. Yeah.
radiologists, all of these people, when you start to think about it, and you can make coaching and a few changes in your procedural areas can make a huge difference that, they're not very costly. That really was my tactic for getting them on board and it worked for me. I mean, it wasn't, like anything, the
Yeah.
first time you go and ask, that you're not going to get a yes. But after 20 years, I'm pretty good at making the case when
Ace.
I
Yeah.
when I want money for something, and this was part of it.
Yeah, no, you bring up an important point, and thank you for advocating on behalf of your staff, not just the surgeons, but all the operating room and procedural staff. And I'm not at your level in terms of leadership, but I faced some similar issues. As you said, there were some wins and there were not, there were some other areas that required work. And I don't have your experience, as you said, in terms of getting, to the heart of the problem. But I will admit that I did feel like some of the barriers were in my head. We're not used to, as a profession, advocating for ourselves. We're very good at advocating for our patients. Maybe we're very good at advocating for ourselves as a profession, but maybe not so good as doing that as individuals. I found that administration at my hospital was also receptive and about making some changes in kind of the OR environment. I haven't approached the coaching issues yet, as you have. Anyway, it was interesting to see.
I think I got a lot of mileage,
Hmm.
honestly, out of insisting on including the nurses and techs.
Yes, yes,
That showed them that it wasn't really about me. It wasn't about the surgeons, right? I was
right.
worried about our people. Hospital administrators, they get a bad rap, but they care about their people. They do. My
Yeah,
president, she is incredible, incredibly caring, and so are the chief nursing officer. And they kind of got it a little bit like, hey, he's not just sticking his hand out asking for money for the surgeons like they always do. It was helpful that way. And I made my share of mistakes. I Whenever you want to get something and you want to load the boat with all of the stakeholders as much as possible, you want to go to them first because the person you're going to be asking is going to go to like hear what they
all
all
the
have to say.
stakeholders. Yeah,
So
yeah,
I went to the chief nursing officer, but I made a couple of mistakes because I didn't completely understand like where some of the landmines might be. So I did not go to my director of environmental services.
I see.
And I also, while I went to the head of occupational therapy, I didn't go to like the head nurse person in that area.
I
And
see.
both of those people, possibly because they hadn't been included, made it harder for me to get some of the improvements I wanted for the OR. They didn't feel like their opinions had been solicited. And
I
this
see.
is basic leadership 101. You want to make sure everyone feels included and you've heard their voice and they get to be a part of the team that gets the win for everyone. And I didn't sort of know all the places I would need to go. I thought I had it covered, and it made it harder.
Yeah. No, I think I made that mistake too. And so I appreciate what you're saying. I think a good place to start for someone like me was the obvious thing was, well, I presented grand rounds and one of the chairs said, you need to come to the surgical services subcommittee. And that's what I often say, that's a good place to start because you have the key stakeholders in terms of OR staff. You have our anesthesia colleagues who also have a high rate of work-related injury, especially with patient transfers. You have our nursing staff and OR scrub techs, and then you have surgeons. And really, it isn't, as you said, really isn't just about the surgeons. We're talking about our people, their career longevity, their contributions to the workplace. And I had the same experience that our administrators were sort of taken aback that we were working and that we had pain and perhaps some of the way things had been put in the OR, some of the things that we could use were going to mitigate some of that. They were surprised to hear that we were doing our job with the pain. So I agree with you in that part there. But, this is such a new area that I think you're sharing your experience about how to go about making this happen at an institutional level will be absolute gold and invaluable information to anyone who is interested in making this change in their own institutions. And I think they'll be very happy that they can reach out to you. We will include Dr. Rubin's contact information in the show notes, everyone. So you went there, you made the case, you got this grant funding. Then you had to go to the staff, the surgeons and the scrub techs. You knew that you were from your prior conversations that they had symptoms of work-related musculoskeletal disease. But how did you then make the case to your staff? How did you get buy-in or didn't get buy-in? What were some of the lessons from that journey?
Yeah, I mean, I took a stepwise approach. The first thing I did was, where possible, I shared my story. And and then I had grand rounds with you. And
Yes.
I invited you, and I to that Zoom grand rounds, I invited all the nurses and all the techs too. And I told them in advance
Mhm.
that I had money and that we were going to offer them the opportunity to have an evaluation and even one-on-one coaching if they wanted it. You and I talked about a couple of different models
Yep.
for
Yep.
how we might do it, including, you coming and spending time here and trying to get to the whole OR. And logistically, it was best to invite people to sign up, as it were. Anyway, after that grand rounds, there was quite a lot of interest. A lot of people email me, yes, I would like to have an evaluation and I would like to maybe avail myself of the coaching. We started off down that road.
Yep. Yep.
And a decent number of people did it, and I have some positive stories. Maybe I'll share my own story at some point. I got the coaching. I do think that not as many people took advantage of this incredible opportunity as might have. There's a few reasons for that. Like, life is busy. Time,
Hmm.
that making time. The method we chose, they had to get someone to video them and
Hmm.
upload the video to you. It's kind of embarrassing to ask someone to video you. And toward the end, I went around with my phone and videoed a whole mess of people who couldn't find someone to video them, and we were able to get a few more people to do it. But the problem with any kind of improvement is that there's sort of a hierarchy of effectiveness, and education alone is low.
Correct. Yeah.
Doesn't really stick with people. And forcing functions, for example, making alterations to the OR that basically mean the default is good ergonomics. That's much more effective. And I think if I were to do it again,
Right.
um, I would certainly offer the opportunity for individualized assessment and coaching, but finding ways to look at the whole OR and all the people working there and trying to make some changes that I was sure would benefit everybody, including the people who were young and didn't get that they needed this. That would be the way to go in the future.
I see. So yeah, lessons learned, and I'm still learning them. And it sounds like you had a similar experience. So I was going to ask you that,
Yeah.
what did you get out of your personal coaching? And then what barriers did you encounter in implementing sort of recommendations, as you said, which might give us a highlight as to what others were facing? So,
Sure. So I'll tell you my little story. And you had sent me articles. I'd like read a bunch of things, and and yet my assessment and my coaching was transformational, actually. I didn't even know that I had this problem. So after my injury, I really stopped doing major surgery, and as a colorectal surgeon, what I was doing a lot more of was colonoscopy.
mm,
And I uploaded my video
videos. Yeah.
to you and your
Partner,
ergonomist.
Linda. Yeah.
Yeah. And so, and then we met and
Mhm.
went over the videos, and she said, 99% of the time your neck is in the red zone. I'm
Yeah.
like,
Yeah.
really? I'm like, I'm just doing a colonoscopy. What the heck could be wrong with my neck? I'm standing there, but it turns out, so she watched the video with me, and she's like, your head is tilted backwards kind of. And she was like, what kind of glasses do you wear? I'm like, progressives. And she was like, well, you're tilting your head back to look through the lower half of your glasses, and it's putting your neck into a position that's very unhealthy.
Yeah,
And
non-neutral. Yeah,
and she
non-neutral.
exactly, and she gave me two options. She's like, if
Yep.
your eyesight's not too bad, you could just take your glasses off, move the screen a little closer, and keep your neck neutral.
Right.
Or you can buy these things called, I think they're called TV glasses or something,
Yeah,
or
they're middle range.
yeah,
Not, yeah,
mid-range
mid-range.
glasses that you could just
Yeah.
put on when you're doing a scope. So
Yeah.
anyway, so I stopped wearing my glasses and I made them move the screen closer and a little lower so that I
Mm-hmm.
would be neutral. And I didn't really realize this, but like I had been having some numbness in one of my hands
Mm-hmm.
and that
Mm-hmm.
like went away. Like
Right.
just from doing that. And you know, I can do right now I'm doing 12 or 13 in a day.
Yeah.
And I'm okay at the end of the day. Even though I thought I knew a lot about it and I'd read articles about it, I without the video, without the analysis of my personal situation and the coaching, I would not have had that benefit. So that's a vignette, if you will, about the value of this.
Well, thank you very much for sharing that. And it kind of echoes what we heard. Linda and I just came back from Seattle. We were doing kind of on-site coaching for gynecology oncologists. And this was discussion about sort of where they do a lot of laparoscopy, obviously. And so the discussion about where the screen should be for those of us wearing progressives was a huge part of this. And it was an epiphany, that, oh my gosh, getting trifocals where you can have kind of a larger range, if you will, for that middle distance, or actually getting middle range glasses for when you're working on the computer or doing scopes or laparoscopy was a huge part of this discussion. And, for our listeners, you can see that, education is good, grand rounds, master class, etc. All these are a good introduction, but really, as you said, making it the environment such that the default option is good ergonomics. And so making equipment, common equipment available, we've talked about anti-fatigue mats, lightweight headlamps, fixing sort of the digital imaging platforms in a place where they're not causing us to straight our necks, in the OR to look at them. All those things, ergonomic design in the operating room is one big piece. And then the second piece would be one-on-one coaching, because let's face it, right? Just as no two patients are the same, no two surgeons have the same exact anthropometrics. There's going to be minor variations in how they sit at a robot or how they're looking at their laparoscopy screens. And also, no two surgeons do the same procedure exactly the same way. I mean, you probably set up your scopes slightly differently from your other colleagues and your in GI and in surgery. So that's why that one-on-one observation is still kind of an important piece of the puzzle, if you will.
I'm glad you mentioned the computer because one of the other
Yeah.
things that you noticed in my analysis and coaching long ago tumbled to the importance of having a standing desk. I
Mm.
have a lot of offices. I have three offices, and
Mm.
each one has a different brand, if you will, of standing desk. And you noticed that one of them was not very ergonomic for me. And I've actually completely stopped using it.
Oh, wow. Okay.
And we spend more and more time at our workstations and computers, with documentation and whatnot. And that is
Mm.
a huge part of ergonomics today. It's not just standing at the operating room table. I mean, I would predict like the next generation, the next 10 to 15 years will be filled with surgeons getting shoulder operations because of laparoscopy. They're all there with their shoulders in the wrong position. That's going to be it's been necks for the last 20 years from people like looking down in open
Down.
cases,
Exactly.
and
Yeah.
now it's going to be shoulders. But the workstation type of ergonomic things are also going to be increasingly important. You asked about the barriers. I'll give you like my barrier story, which has a little to do with my environmental services and occupational health faux pas. But as I realized that not everyone was going to take advantage of the coaching and one-on-one, and sort of moved my mindset more toward modifying the ORs to default to better ergonomics,
Hmm.
I wanted to install anti-fatigue mats, which there's now quite a good bit of
Hmm.
evidence for the benefits, and it's not just like your feet. They have benefits for hips, knees, back, etc. So
And
um,
fatigue. Yeah, and fatigue.
exactly, and I was like, well, not everyone's going to sign up, but if we put anti-fatigue mats on either side of the OR tables, people will stand on them and get
Hmm.
the benefits.
Right.
So anyway, went and I looked for both affordable and, cleanable, um,
Yep.
you know, submitted a purchase order and I had the money. That
Yep. From the grant. Yeah. Yeah.
wasn't the problem, but here are some of the problems. Turns out that the vendor wasn't an approved vendor by by system.
I see.
Okay, so that was problem one. Problem two, the environmental services people, like this was the approach that they took, which seems backwards to me, but they're like, we would have to use a particular kind of solution, which isn't the one that we currently use to clean these safely. And if we keep using the one that we currently use, which will clean them, their lifespan is shortened. And then what do we do when they're worn out and have to buy more? I had sort of a, well, why don't we cross that bridge when we come to it? They have a
That would be the exact question I would ask too, Mark. So I
they have a
get
10-year
it.
lifespan.
So
They have a 10-year lifespan. Even if you destroy them in 5 years, like we got 5 years out of them, and by then, maybe things will be easier.
yeah,
So that was a problem. And then the amazing thing to me was the occupational health people complained about the potential for a tripping hazard. I mean, these
I
things are
see.
like a quarter inch tall. As a, surgeon, a snarky surgeon, I sent them a photograph of my OR, which had like all sorts of wires going
Trip
across the
hazards.
floor.
Yes, trip hazards.
Hazards, way, way worse.
Yep.
Didn't matter. They
Yeah.
they they hadn't been heard,
Right.
and they stuck with their tripping hazard thing. And at the end of the day, I was unable to use the grant money for that purpose.
Oh,
Uh,
wow.
yeah, it was a real loss, and I went all the way to the president of the hospital.
I
Uh,
see.
and the head of occupational health at not just my hospital, at all of Mass General Brigham, and I couldn't get over the goal line. Now I'm going to get those anti-fatigue mats. Sadly, I think the organization's going to now pay since the grant's expired,
I
but
see.
the evidence is there.
Hmm.
The issues brought forward were, to me, minimally consequential,
Hmm.
and the case still is still strong. So, but those were the kind of barriers that I encountered, and then just the surgeons and nurses, they're busy, that it's meaningful. They wanted to do it, right?
Yep.
It was meaningful to them, but it was too hard to get the one-on-one thing to happen. And
Right.
as you know, what we're doing next is we're going to do some sessions for the whole OR and the whole endo area.
Hmm. Hmm.
And we're going to look at some videos of, in general, of those
Hmm.
areas and try to do something that gets more people into ergonomics.
Yeah. Yeah. No, you're absolutely right on all these counts, and we faced similar issues at our institution regarding mats, not exactly the same, but similar regarding sort of what does it do to the workflow of the environmental services who have to clean them, what is the procedure to clean them, etc. But overall, I mean, they're a low cost intervention that can have potentially big dividends. And I realized another blind spot this weekend of coaching. Linda and I realized another blind spot that a lot of people have actually got access to anti-fatigue mats in their operating room, but they didn't use them because they stand on steps. So they had the full ones, but they didn't have the little ones that are stable on the steps. So there is a knowledge gap. And then, of course, there is this implementation gap, hurdles, if you will. But we'll get there. We're surgeons and OR staff, and we're all kind of trying to improve things.
Lots of low-hanging fruit.
Exactly. And this is part of that low-hanging fruit. And I have no doubt, you and others will be able to implement this as time goes on. Which kind of, I think we're reaching the end of our time, but this particular discussion that we just talked about is actually a great way to kind of lead me to maybe the last question, maybe not, we'll see, which is given sort of this local environment, do you think our national organizations, not just the college, I mean, I know the college has its ergonomics task force and it has its recommendations, but perhaps even our specialty organizations need to get involved. And how can we make changes there that it's not an option, meaning, individual leaders like yourself don't have to go and advocate for these things. I mean, it should be considered standard. There are guidelines. JACO looks at how things are set up in the OR. How can we hardwire this at a different level? I guess is my question.
I definitely think that specialty societies should embrace this. And truth be told, when you speak at I'm speaking about you now, not me, but when you speak at a specialty society group of surgeons, they do like a small number of procedures with a similar risk profile for them. That this group is at risk of A, B, and C because they do cases 1, 2, and 3. Right. And
Right,
then you go to the next subspecialty group and it's three different cases that are they're big three and maybe different parts of the body and different things that need to be looked at. So I
right.
think going foxhole by foxhole like that has merit. Personally, I would love to see the Joint Commission
Hmm.
um, looking at this instead of the ceiling tiles that are stained or whatever it is that they're looking at as safety hazards. I'm nervous about that as a person who has been through a lot of Joint Commission visits.
Right.
They'll cite you and then your organization must comply.
Hmm.
And sometimes compliance is very expensive. I don't know
Right.
what the Joint Commission would recommend. And, they could recommend something that's prohibitive for, critical access hospitals to afford. I don't know.
Good point. Yeah.
And so heavy-handed approach, I much prefer the we're going to fix this ourselves approach. I do think that hospital margins are tight
Yep.
and finding, you need to work with your hospital to make these changes. Maybe, it happens slowly over time, or maybe you get grants from outside. They work with you to get grants to pay for it. I don't know, but working with your hospital so that they don't really bear the brunt of a heavy expense, working with specialty societies to help design the correct changes, relying on forcing functions or things that make it easy to do the right thing, uh,
Hmm.
rather than just educating people. These are the kinds of things I think are going to be most helpful.
As you were speaking, I of course came up with one more question, which will be the last question, because I think people will want to know, given what you've talked about, you've described sort of the wins and minor losses, minor failures. We always fail forward. You learn lessons that you've had in this experience. But tell me a little bit about, is there now a mechanism at your hospital or hospital system where if people are having symptoms, they can, where do they report to? Do they report? Are they encouraged to report? Rather than having these injuries get worse and worse and then have an acute event, is there a mechanism? Because that's part of building this culture of good ergonomics, right?
It's a great question, and perhaps something that should have more attention paid to it, because while we have a mechanism, the culture is really not to self-report these things still.
Right.
And I know maybe it takes a generation to change culture. It takes a while anyway.
Yeah.
I mean, I've said to my people, if you're having symptoms, please come talk to me. Who knows if they will or won't. There's certainly risk to going
Hmm.
out, and risk to speaking up to your employer. But I feel we need to create a safe way for people to do this. It's their health. We have those ways for mental health right now. There,
Correct.
yeah, I think it's something that we probably, while we've given lip service to saying that it's available, we haven't really walked the walk well enough there. And
Yeah.
it's an opportunity. I'm not really sure how to make it easier and more acceptable. I don't want people coming to me when they can't lift their arm.
Right.
You know,
Right.
I'd like to know about it and be able to do something about it, or at least if they go to their physician or they go to Occ Health, all acceptable options. We make accommodations. We have to make accommodations.
Mhm,
When
mhm.
someone comes from Occ Health and says this person needs X, Y, or Z, and those accommodations get made. It's
Yeah.
the law. We have to make it easier for people to do that.
Agreed. Yeah, and that's one of the areas we talk about when we do master classes or, also in individual coaching, encouraging people. We understand why you don't want to report, but it's important that you at least speak with your family physician and or Onc Health because that's what we have right now. But I wonder if we need to structure it more along the lines of sort of as we have with mental health, seeking
Yeah,
mental health help because people still feel like, this is going to be part of my medical record and what if, it's my livelihood. So lots of work to do in the area, but like you said, there's all these are areas of opportunity for all of us and including all the leaders at various levels. And again, I am so grateful that you're here and thank you very much for your time and your expertise and really being so deeply invested in the physical well-being of, all of us working in the OR and procedural suites. I think this episode will be eye-opening to a lot of our leaders. All right, thank you very much. Please remember to subscribe to the podcast and follow us on social media. Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.